Right. Thank you very much, Tom. And it's again an honor to be on the platform with you. I won't say that very often, but it is. Our first speaker, who we're delighted to have, is Dr. Francesca Mara, who's a gynecologist in the Institute in Rome, and her specialist research area is in ultrasound and gynecological oncology. And she's going to take us through the basics of transvaginal ultrasound in the normal gynae anatomy. And it's really important to understand what normal is so that you can understand when you see the abnormal. So this is a really crucial lecture. So we're just going to hear from Dr. Morrow shortly.
This is my presentation, the basics of transvaginal ultrasound examination, including normal gynecological anatomy. In this presentation, we'll discuss how to perform a transvaginal examination, how to optimize the image, how to assess uterus and ovaries, and how to assess ureters, parametria, and more. First of all, how to perform a transvaginal examination. We can first insert the probe in the vaginal introitus to visualize the urethra, bladder, vaginal wall, and rectum. And then we insert the probe in the anterior vaginal fornix to visualize the cervix, myometrium, and endometrium. This is the cervix. We can visualize the anterior lip, the posterior lip of the cervix, and the cervical canal. Then, moving the probe laterally, we can visualize the uterus and the endometrium. To visualize the pelvic organ, we have to insert the vaginal probe in the anterior vaginal fornix, and then we can assess uterus, cervix, and bladder. It is important to check the caliper position. It can be on the right, on the left side of the screen, at the top, but also at the bottom. I usually scan with the caliper in this position adjacent to the bladder. How to optimize an image? In this slide, we can visualize our screen with the uterus, and on the right, we can see the machine. To optimize the image, we can use depth, focus, and zoom. Using the depth, we can increase the image. The region of interest, in this case the uterus, must occupy more than 75% of the screen. Then check the focus. The focus should be just behind the area of interest. This is the incorrect, the wrong position, and this is the correct position, behind the area of interest. Real zoom. Real zoom helps to enlarge an image section on the monitor without the graining effect. For example, if you want to better visualize the endometrium, we can use real zoom to enlarge the image. We can measure it, and also we can assess the vascularization. This is the real zoom. Then frequency. Usually we use general frequency, but there are 3 frequency settings, including resolution, high frequencies to investigate superficial structures, general, or penetration, less frequencies to study deeper structures. Frequency and focus, we can obtain the correct image. But also we have to check the gain to obtain the correct color of the image. Color Doppler examination. First of all, we have to check the PRF. The PRF should be between 0.3 and 0.6. In these two images, we have the same ovary with the corpus luteum. On the left side, we can see the wrong PRF, 1.5. On the right side, we can visualize the typical vascularization on the corpus luteum. So PRF is very important. Then it's important also to adjust the gain of color Doppler examination. Usually to adjust the gain, I increase the color gain until the appearance of noise, and then I reduce the color gain until the disappearance of noise. Then we can obtain the maximum color sensitivity without noises. So, color Doppler examination. Then, how to assess uterus and ovaries. This is a uterus, and we can move the probe side to side to assess all the organ. Then we rotate the probe 90 degrees to assess the same structure in a transversal section. And then we should move the probe from the fundus to the cervix in order to assess all the uterus. We measure the uterus. The first is the long axis from the fundus to the cervix, then anterior-posterior diameter from the anterior to the posterior wall, and then in the transversal section, we can obtain the third parameter. With real zoom, we can measure, we can identify, we can study the endometrium, and we can measure it. This is another video showing the uterus with a normal thin endometrium, and moving on the left and on the right side, we can assess the ovaries. After the visualization of the ovary, we measure it in 3 diameters. We can also assess the vascularization, and then we can assess the ovarian mobility. Transvaginal ultrasound examination is a dynamic examination, and by pushing the ovary against the surrounding organs, we can assess the mobility. Surrounding organs including uterus, bowel, the sacrouterine ligament, and the pelvic side wall. In this case, the ovary was free. What about this ovary? This ovary is fixed to the bowel, but also to the uterosacral ligament. Now, how to assess ureters and parametria? To investigate the ureter, a longitudinal section through the cervix should be obtained, and the probe can then move towards the lateral pelvic wall in order to identify the caudal part of the ureter next to the bladder. The ureter is a fusiform anechoic tubular structure next to the bladder. We can visualize the ureter here and the uterine vessels. Now, parametria. This is a scheme recently published by the IDEA group. I would like just to show how can you assess on transvaginal ultrasound examination. In particular, we can assess the ventral parametria, so the structure between the bladder and cervix, the lateral parametria, the structures between the cervix and the pelvic wall, and the posterior, the uterosacral ligaments, the ligaments between the cervix and rectum, and medially the rectovaginal septum. Ventral parametry. In this video, we can observe how to assess the vesico-vaginal septum. This is the bladder, uterus, and vaginal wall. And pushing the bladder against the vagina and uterus, we can assess the movements, we can assess the septum, which is free in this lady. This is a patient. This is a patient with an endometriotic nodule infiltrating the bladder. In this case, the septum is fixed. Now, how to assess the anterior ligaments, in particular the vesico-vaginal and the vesico-uterine ligament? This is a longitudinal section, and we can moving laterally the probe at this level where the ureters is next to the bladder. We can visualize this hyperechoic tissue corresponding to the vesico-vaginal and the vesico-uterine ligament. I would like to show you again. So, bladder, ureter, and this is the hyperechoic tissue corresponding to the vesico-vaginal ligament and vesico-uterine ligament. Now, how to assess lateral and posterior parametrium? First of all, we have to assess the bladder and ureter, and then we can move the probe 90 degrees to obtain this transversal section with the ureter in the middle. Here is the ureter, and next to the ureter, we can visualize the uterine vessels. This is the cervix, this is the vaginal wall, uterine vessels, ureter, and pelvic wall. This is the structure between cervix and pelvic wall corresponds to the lateral parameter. Then, to assess the posterior parametrium, we can obtain this section, transversal section of the cervix. Then we can visualize the cervix and the retrocervix. Then we can move our transvaginal probe on the right and then on the left side to assess the hyperechoic structure behind the cervix and the uterine vessels on the right and on the left side. We can also assess the uterosacral ligaments in a transversal section of the cervix. Again, this is the uterus, cervix. We can obtain a transversal section of the cervix, and here on the right, behind the uterine vessels, and on the left, we can visualize, we can assess the ligaments. Then we can move the probe more deep to assess the rectovaginal ligaments, that are the ligaments in continuum with the uterosacral ligaments. Then, inserting the probe in the posterior vaginal fornix, we can assess better the uterosacral ligaments on the right and on the left side. Finally, to assess the rectovaginal septum, we can obtain this transversal section to visualize the cervix, vaginal wall, and the rectum. it should be here. And this region between vaginal wall and the rectum corresponds to the recto-vaginal septum. This is an example how to assess the recto-vaginal septum. Again, this is the cervix, this is the vaginal wall, this is the rectum, and here we can assess the recto-vaginal septum. We have summarized this methodology in a video. Finally, we can also assess pelvic side wall, in particular external iliac vessels, internal iliac vessels, and sacral plexus. In this video, we can recognize the external iliac vessels. Then, moving the probe medially, we can recognize the internal iliac vessels. And then, from the internal iliac vessels, we can visualize the anterior branch and the posterior branch. And these hyperechoic structures between the two branches correspond to the sacral plexus. Then, moving the probe more laterally, we can observe the obturator muscle. Finally, next to the nerves, so to these hyperechoic structures, we can visualize the piriformis muscle. In conclusion, to optimize the image, we can use depth, real zoom, focus, frequency, and gain. Then, color Doppler examination, please check the PRF between 0.3, 0.6. Uterus, ovary, and their mobility can be assessed very easily with the transvaginal ultrasound examination, but also we can assess ureters, parametria, and muscle, vessels, and nerves. And thank you very much for your attention, and enjoy the rest of the course.
So thank you, Francesca. I can see you've joined us. Welcome from Rome. Nice to see you.
Hello. Morning, everyone. Thank you very much.
So thanks once again, because time is short for a great talk. So when I look at this, I think some people who are starting with transvaginal ultrasound, it's almost like when you do a language course, and I'm always very good at saying, hello, I want to go to the airport, and then within about 2 minutes of the course, I have no idea what they're talking about. So if you're talking about starting, do you think people can, for example, look at the uterus and always have a standardized plane, longitudinal view? So how do they make the leap from what you might call that sort of basic starting point to getting the feedback? Because obviously with your images, you get nice images, you can see the uterosacrals and so on. I personally found that when I started trying to extend beyond, was that the ureter is almost the easiest thing to start with, because it's basically doing that. So how did you extend your knowledge? What's the secret? Just repetition, or going to the operating theatre?
So thank you very much. And just to summarize, first of all, it's important to know the anatomical side. So because I think now up to now, everyone knows how to perform an ultrasound examination transvaginally, how to assess the uterus and ovary. But also we can do more with ultrasound examination. So we can assess the ureters, parametria, septum, because it is a dynamic examination. But recently we can also, we are trying to assess more vessels, muscles, and nerves. It is not very difficult, but we have to know where we can find them and try, when we scan, usually I scan a lady and try in particular a normal patient to find these structures in normal lady.
So every time, I always feel every time
Exactly. Every time you need to check. And also, it's important, for example, when someone asks me to explain how to perform an ultrasound examination, to obtain the best imaging can I do. For example, using the depth, the zoom, check the gain. I think they are very important, in particular for when we want to assess the vascularization of an organ. So first of all, I think you have to set the machine, and then we can start to assess the pelvic structures.
So make sure your machine is optimized to get that you've got the best setup. Secondly, know what to change in terms of depth, focus, etc. And then obviously you're saying you have to pay attention to the anatomy. If you know the anatomy, you're going to be in a much better position. And then finally, remember to do the same thing with every scan. So, if you have a normal pelvis, that's probably the best way to start. Always just look for the ureters so it becomes part of the daily habit. Is that a fair summary of what you're saying?
Yeah, exactly.
Yeah, perfect. And I think it's going to become clearer as the day goes on how important this anatomy is, because we're going to have you back later for the oncology session. And I think whilst initially perhaps looking at parametria and so on might seem a little bit advanced, when you look at the potential in cervical cancer assessment and so on, this is where this knowledge of the anatomy is going to become absolutely essential. And I think in some environments, particularly where cross-sectional imaging is not available, I think when we talk about assessing cervical cancer, for example, a lot of what you just shown is going to be super relevant.
Yeah, exactly. So when I spent some time with Antonia Testa and with Professor Curley and other colleagues to better understand how to assess parametria. And I scanned like 20 ladies with normal pelvis, and then I learned a lot, and then I was able to recognize the infiltration of anterior, lateral, and posterior parametria in patients with cervical cancer. I show later some videos.
Yeah, no, well, I think you're right. I think when you look at obstetrics and you start doing obstetric scanning, you just learn the sort of the various planes. You just start off saying that doesn't look right, and then you learn the various things. It's the same with gynecology, actually. If you learn to if you know what normal is, and you even if you just say that isn't normal, and then someone can help you, that's a major step. Francesca, that's a fantastic lecture. I'm going to move on now, if that's okay, because of time. I know you're kindly joining us later, and we're going to talk about cervical cancer, and we've got some nice cases to show. So you can go off and have a nice. What do you have in the morning in Rome? Are you allowed a cappuccino in the morning? No, you can't. You can't have cappuccino in the afternoon. I think that's not allowed in Rome, is it? Is that right?
No, in the morning.
Just only in the morning. Perfect. Yeah. Well, you go and have a cappuccino, and we'll see you later on. Oh, hang on, Theo. Theo wants to ask a question. Hold on, or has a comment.
Hello, Francesca. Thank you very much for this really important talk. I just wanted to stress that in my experience in a number of countries I've been to in sub-Saharan Africa, transabdominal pelvic scanning is still being done because there's this reticence to do transvaginal. And certainly where I've gone in Malawi, Rwanda, and Ghana and taught transvaginal scanning, they have said it's like doing transabdominal scanning and then putting your specs on. But there is this reticence to do it, thinking that women will not accept it, but actually they will when they understand that it's actually going to give them a better scan. And your excellent talk shows even beyond the basics just how much you can see, and that really sets the scene for the rest of the day, and as Tom says, the things we're going to see. So it's absolutely crucial that people are doing the pelvic scanning transvaginally where possible. I can see some people asking for some other parts of your talk to be redone. All these talks will be available on demand, within a few days, and you can revisit them. Thank you very much, Tom. Back to you.
Thank you very much. Thank you very much for your comment.
I mean, Theo's absolutely right. I do think with patients, very often they're under the impression that it's the same scan. I want it abdominally, I don't want it vaginally. When I think they need to understand how much more information you get vaginally. And I think once people realise it's in their interests, I think it's a slight myth, because people want what's best for them at the end of the day. Thanks, Theo. And I think it's something we need to address a bit. And I mean, because a lot of, and it's not just necessarily acceptance. In some places, people don't have a vaginal probe. They might just have a handheld machine or something. I know that there are vaginal probes coming along for the handheld machines, but they're not all there yet. So we're going to have to move on. Francesca, see you later. And we're going to move on to our next speaker.